The International Digestive Cancer Alliance, otherwise known as IDCA, with the logo seen on top, is the oncology division of the World Gastroenterology Organization, WGO. Its origin was in 2002 in Rome, with many organizations sponsoring it. We have one of the founders of one of the organizations, CRPF, Cancer Research and Prevention Foundation, now known as Prevent Cancer Foundation, Bo Aldeje, who you've heard about, who is here today. And I was very pleased and honored to co-chair this at the beginning with Meinhard Clausen, who unfortunately is not here today, in 2002, and he continues on as the immediate past co-chair, and Guido Titgat is sharing this chair with me at this time. The late Pope John Paul II was an important sponsor and promoter of the IDCA, the mission of which was to promote the screening, early detection, primary prevention initially, and then more recently also the management of pre-malignant and malignant disease of the digestive tract worldwide. So it's digestive diseases worldwide through an international alliance of organizations that share the same goal. And there are many such organizations. The IDCA was founded because when we looked at the incidence and mortality of digestive cancers compared with other cancers around the world, you'd see that digestive cancers accounted for the highest incidence and death rate of all cancers worldwide. 3 million incidents each year, deaths 2.2 million each year. And among the digestive cancers, colorectal cancer had the highest incidence, and so the main objective of the IDCA is directed towards colorectal cancer, but also some of the other very important cancers which have a high mortality, such as stomach, liver, and to a lesser extent esophagus and pancreas, especially familial pancreas cancer. And it's very striking and dramatic that the colorectal cancers worldwide, by estimate from the IARC, will be increasing over the next 20 years. Now, not 20, it's 20 years from the year 2000, according to IARC, without intervention. Of course, we hope that these numbers will not increase to this extent. But these are projected based on the enlarging size and population of the various countries around the world, both developing and developed countries, and also with the increasing age in many countries around the world. Now, there are many options for screening, which you heard in the very wonderful talk by David Lieberman, and also in the high-risk groups. For example, in the United States, there's been an evolution of colorectal cancer screening guidelines. Prior to 1997, there was really no consensus worldwide that screening was positive. The options were many options that were long-standing, mainly by the American Cancer Society and other groups around the world, FOBT, flexible sigmoidoscopy, and even the now defunct barium enema. In 1997, there was a positive consensus because there were trials that had matured to the point of demonstrating that our population-based fecal occult blood testing provided a reduction in mortality with an intention to treat analysis of the entire population. And so at that time also, in a committee that I chaired, colonoscopy was first introduced as a screening option in 1997. This was added by the U.S. Multi-Society Task Force, and Bernard Levine, who is here, chaired the American Cancer Society Committee that also recommended screening colonoscopy as an option. In 2002, the U.S. Preventive Services Task Force upgraded the evidence to a grade A, which is top grade. And in 2003, new tests were introduced, new options, fecal immunochemical test, which you heard about, and a sensitive fecal occult blood test. And now you've heard from David Lieberman that there is an emphasis on prevention versus early detection in the U.S. guidelines, especially in the U.S. Multi-Society Task Force guidelines. So there are many options available for screening. And we don't like to think, we think that colonoscopy is the best option, but there are many options, and colonoscopy is not always available for either screening or even for diagnostic workup. So the cascades in gastroenterology in general is the best you can do with what you have. Of course, we like the best. When we say the best, we mean high quality, of course, but use the options that you have. And for colorectal cancer very specifically, the screening cascades are based on a hierarchical set of options ranked by available resources, resources being defined as medical and financial to a large extent, but there are, of course, we know many other resources that are needed. So the Cascade method is evidence-based on a very fine literature search, but it is not evidence-driven. It applies existing knowledge to improve health care, which is what we heard from Dr. Scheich, that we want to improve health care by using existing knowledge and apply that existing knowledge with everything we know right now. It works with what we have based on resources and takes into account population risk and population preferences and many other factors. It also takes into account other health care priorities. The Cascade method-based guidelines have now been approved by the U.S. National Guidelines Clearinghouse and is now listed on their website. And WGO has translated this into many languages for wide dissemination. Now, you've seen from David Lieberman this map of colorectal cancer risk. This is mortality in males around the world. We know which countries have a higher risk. Within each country, there are variations geographically and also by lifestyle and many other factors. But countries have other concerns too, and this is, for example, the HIV/AIDS worldwide in the countries that are at greatest risk. And also countries have a high population risk of HB viral infection. So countries need to focus on what is their health care priorities in terms of colorectal cancer and how that fits in. We gathered a very fine review team to develop these guidelines from around the world, and I was privileged to chair this with Meinhard Claassen and Renee Lambert, who's at the IARC, and has provided many of the data maps that I've shown you here today, and we've had consultants here also, none of whom are present. We do have Bernard Levine here and David Lieberman here, who are on the review team, and have been very helpful. So the colorectal cancer screening cascade hierarchy goes from highest resources in a country to minimal resources in a country. And this is one suggestion of the hierarchy. For example, in average risk screening at resource level 1, where there is extensive colonoscopy resources and facilities, colonoscopy can be recommended every 10 years, starting at the age 50. And of course, increased risk screening can be focused in those increased risk groups. Now, an example of a high resource area is New York City. And in New York City, we developed a colorectal cancer screening program and a coalition in conjunction with the Department of Health. Corinne Melli will present this later on in terms of the results of the New York program. We have Steve Itzkowitz here, who's been extremely active, and Tom Weber, who has co-chaired this with me since the beginning. The guidelines in New York City are for average risk men and women, age 50 and older, to have colonoscopy 10 years as a preferred test, which fits in very well with the new national U.S. Multi-Society Task Force guidelines, and then alternative testing for fecal occult blood. So we thought in New York City, high resources, give a simple message, straight message, colonoscopy preferred, and we felt we could do it based on surveys that we did in New York City. Now, this is one survey which was done and provided very kindly by Laura Seif, who was here from the CDC, showing the variation in endoscopic resources in New York State, 441. And you can see the skewed distribution of urban, like New York City, versus rural resources. And this distribution in New York City allowed us then to go to make the recommendation that screening colonoscopy is a test of choice. Whereas in the rest of New York State, the resources are very limited, and so the state comprehensive cancer plan focuses on FOBT, but they're now adding screening colonoscopy as an option, but not the main option. And we have achieved great success as a result of the very big efforts by Tom Weber and Steve and many other people in New York City. Moshe Scheich is here, and he's participated. And there are a number of other people here involved, showing the increase of colonoscopy for screening in the at-risk population in New York City from 2003 to 2006, and increasing from 42 to 60%. And the pie in the sky goal for 2011 or 2012 is 84%. We're not sure we can reach that goal, but that's the goal we're striving for. And Mark Bachapin is shaking his head. He's also very, very involved in the C5, which we call that the C5. We can't say the whole name each time. Now, for resource level 2, where colonoscopy resources are a step down, then colonoscopy perhaps can be offered once in a lifetime. And when we go to resource level 6, as an example, and all of the details of these resources and recommendations may be seen on the WGO website. I'm just giving you just a very minimal outline. For resource level 6, average risk screening with FOBT, but every year. As you heard from David Lieberman, doing it once is not very effective. But even with the FOBT choice, there are many different slides, as we heard this morning. And for example, where diagnostic colonoscopy resources are limited, and based on the population compliance, then a very high specificity guaiac test like Hemocult, which we don't use very much in this country anymore, or FIT, which is becoming more popular, can be used. Whereas if diagnostic colonoscopy resources are readily available, then we could go to a more sensitive guaiac test, because we know there'll be many more false positives, but we need to do more colonoscopies. And there are alternatives in high-resource countries and high-resource areas, which include stool DNA testing and CT colonography, which we've also heard about, and perhaps there will be more discussion about this later. So in summary then, our worldwide goal for all of us, and that's why we're here today, is to increase colorectal cancer screening in people at risk to reduce the unacceptable 1,500 deaths from colorectal cancer that is occurring around the world each day. There are many specific, geographic-specific guidelines that are available. We've heard of the US guidelines, European guidelines. There are many options. They basically fall into two categories: direct screening colonoscopy or a targeted colonoscopy based on a first step screening test such as FOBT or DNA testing or CT colonography. The international guidelines are cascade-based. They're meant to be applicable to many countries around the world, not just high-resource countries, but developing countries that may be seeing an increased risk of colon cancer. It takes into consideration medical and financial resources and healthcare priorities. And basically, the concept is do what you can with what you have. So among all the options, what is the best screening test that we should select? The best screening test is the one that gets done. We know that if somebody does a screening test for colorectal cancer, their likelihood of getting colorectal cancer, the likelihood of dying from colorectal cancer is less than somebody who does not have any screening test at all. And I inserted this last point on my slide at the urging of Dr. Levine, who is here, and of course Dr. Lieberman. Must be done well. Thank you.